Just a quick reminder that the information discussed on this podcast is for informational purposes only and is not clinical advice. Discussion of specific products, services, or protocols does not represent sponsorship or endorsement.
Hello and welcome to Talking Heads, the official podcast of the Sports Neuropsychology Society. I'm Dr. Danielle Kaplan.
And I'm Dr. Kate Higgins.
Today we have Dr. Shawn Eagle with us. Dr. Eagle is currently a research assistant professor at the University of Pittsburgh in the Department of Neurological Surgery. He has collaborated with the Department of Defense-funded research through the University of Pittsburgh since 2013. He began focusing on traumatic brain injury in 2015 when he began his doctoral studies at the University of Pittsburgh Neuromuscular Research Laboratory. Dr. Eagle completed his postdoctoral fellowship at UPMC Sports Medicine Concussion Clinic. His research interests are currently focused on mitigating risk for long-term sequelae following traumatic brain injury, with specific focus on mental health issues. He has published over 100 peer papers in peer-reviewed journals and presented his research at local, national, and international scientific conferences. Welcome, Dr. Eagle.
Thank you so much for having me.
So as we know, concussions have emerged as a critical issue in both medical and sports communities, warranting extensive discussion and examination. The importance of this topic extends beyond the realm of professional athletes, impacting adolescents and anyone at risk of repetitive head trauma. Addressing the complexities of concussions involves not only understanding the medical implications, but also exploring preventative measures, risk factors, mitigating factors, and the relationship between concussion and mental health. In particular, CTE has become an important topic of research and discussion. We invited Dr. Eagle to speak with us today about his research in this area and recent advancements in the field. I want to hit on several areas of your research today, but to start out, one of your areas of interest is the mental health aspects of concussion, which we know can be particularly challenging in adolescents. Can you tell us about what your research has identified as risk factors, modifiable factors, or positive prognostic factors in this population?
Yeah, this research topic is very important to me. Through our work, when I was at the concussion specialty clinic here at UPMC, we saw a lot of adolescents deal with these issues, especially after having a concussion. And there are different ways that these can display themselves, for lack of a better term. There are some people who report not having a psychiatric history, but when you start to dig a little deeper, it sort of seems to suggest that maybe they did have issues with anxiety or depression. It just wasn't formally diagnosed before the injury. And now they have a neuropsychologist right in front of them who's able to educate them about these things and help. But, that is definitely the primary risk factor for worse psychological outcomes after concussion is a history of depression, anxiety, or other mood or psychiatric disorders. There are other things that are less obvious than that. There are risk factors in the way that you respond to the injury individually that can increase risk for psychiatric issues, like really high extreme vestibular dysfunction is associated with anxiety and depression following the injury. Issues with sleep is almost always going to co-occur with mood issues. Things like that can develop after the injury should be noted for sure.
Yeah. When you're talking about the way that somebody responds maybe to the injury, especially in the vestibular symptoms that they might express, what have you seen within that realm?
Oh, wow. That is a very broad area, and you can present in a lot of different ways. I strongly encourage the involvement of a vestibular therapist in the management of concussion with vestibular dysfunction. Use of the vestibular ocular motor screen, which was developed at the University of Pittsburgh, can help identify somebody who has those issues after having a concussion. But there are all types of presentations related to vestibular dysfunction, and you really need a nuanced professional to be able to tease out the best way to target those and improve outcomes.
Dr. Eagle, as far as modifiable factors, one of the things that at least I have not seen a ton of research on is if we do good mental health treatment for a patient prior to their concussion injury, does that make any difference in their experience of mental health symptomology after that concussion? Um, yeah, is there efficacy in being proactive about obviously there's efficacy in treating mental health conditions, but do we see any differences or has there been any research on differences then in concussion experience?
That is a fascinating point. Nothing is coming to mind of showing that, but it certainly makes sense. A well-controlled psychiatric issue is certainly different from a non-diagnosed or untreated psychiatric issue. But that's something that certainly makes sense and should be digged into a little bit deeper, because you're right, there are a host of non-modifiable risk factors like female sex, for example, which is dramatically associated with worse psychological issues after having a concussion. But earlier screening for mental health issues should be standard in athletics at baseline assessments, or after any injury, let alone concussion.
I know at least in the collegiate athlete world, there has been a huge push for mental health care, doing screening early and often. And it seems like the field is ripe for like, let's figure out if we can be helpful before the injury, as opposed to just trying to come in on the backside and fix what's already there.
Absolutely. The NCAA has done a nice job of incorporating mental health more and more into their standardized, action plans. That message is more so for the, mid or small level high school who has one athletic trainer for all the sports teams. That can be hard to do, to screen all your athletes for different issues, but there are very short validated screeners out there, like the Patient Health Questionnaire 9 or the GAD-7 for anxiety. Those are 9 and 7 questions respectively, and you can really get at these issues quickly. It's worth taking the time to do.
Absolutely. What has your research shown about the predictive biomarkers in MTBI, and how do you think that translates into clinical care?
Yeah, I think this is the future of concussion management, not necessarily just in blood, but in a biomarker can really be anything about you that can be used to understand how you may respond to an injury or how you may respond to treatment. And that's what we've started to look at with predictive blood biomarkers. We have a series of studies from a chronic traumatic brain injury population where we had blood taken before an intervention, and then a 6-month targeted intervention was proffered to each of these individuals specific to their individual needs. So they're not assigned to a group; it's targeted to them. And then they come back at 6 months, get blood again, and do reassessments. And what we did with that study was look at the change in all these outcome variables for these individuals. One of the key points of that study, and this is the way the field is moving, is assigning each of these individuals, a recovery trajectory, or a clinical profile, or a subtype that is reflective of their current state, and targeting those issues predominantly with the treatment plans, right? So in chronic, we see a lot of psychological issues. A lot of these people had psychological problems, but we dug deeper into that: post-traumatic stress, anxiety, depression, and actually we just have a paper coming out about this in Journal of Neurotrauma that was just accepted from this cohort. But looking at what we found was that baseline blood levels can be very predictive of the degree of responsiveness to treatment when it's targeted to specific issues. And there are certain blood markers that are associated with different outcomes. And if we've been saying for a long time now, 10, 15 years, that this is an individualized injury, we need to target to individual people, but we're still looking at this group as a whole, especially in research. So we need to isolate into these groups. So we've done this now with sleep issues specifically. We've done it with kind of an overall concussion symptom score using the post-concussion symptom scale. And we've done it now with psychological issues, specifically anxiety, depression, and post-traumatic stress. And it's really exciting to think of, having a blood test that you can give someone before they start treatment to know if this is going to work for them or not. That is what drew me to that kind of research.
Yeah, I think that's really interesting. And the way that you see it now, or at least where you think it's going, if we are able to have these predictive biomarkers, who do you think should be part of that team that then decides how to tailor treatment? Is that the athletic trainers? Is it neuropsychologists? Who do you think would be best to serve that?
Everybody. This is best managed as a group, always. That's not always the case. I'm an athletic trainer by training, so I have bias in that area, but I have seen at the high school level, the college and the pro level, the athletic trainer has just different access to athletes specifically than other medical professions. So they have this relationship in both directions with the medical staff in general and the athletes and the coaches. So I see them oftentimes as the point person for that, but the design and putting it together in the baseline evaluation should happen as a group. There are things an athletic trainer can't validly assess for. A neuropsychologist would be more appropriate. There are things a vestibular therapist should be involved with if you have access to. There are headache, migraine specialty things that can be used. So this is a multifactorial problem, and it requires a multidisciplinary team.
I also wonder if being able to give the individual or the athlete some level of certainty that you're tailoring the treatment to them and that this is the best treatment for you would influence their thoughts about it and then downstream kind of influence their mental health and recovery too.
You would think so. We've seen in the room a lot of times with these patients, just the confidence of the clinician who's leading their assessment and leading their management play a huge role in that person's confidence in themselves and confidence that adhering to these programs are going to help them long term.
I'm curious if you can speak to, I'm curious about the specific interventions that you did for some of these mental health conditions. I would say sort of anecdotally, lots of times I don't see my patients respond to sort of traditional talk therapy the way I think they would if they were not concussed, if we didn't have autonomic dysregulation. Can you give us any more insight into that? Like what the specific interventions look like?
Yeah, so the study was called, the acronym was Team TBI. It was a Department of Defense funded research project, and they enrolled approximately 100 people into it over the course of several years. And frankly, I don't think this study received the credit it deserves. It was a little bit ahead of its time. And it's just a data set that I inherited in my current position and being able to use. So I was not a part of this. I'm not promoting my own study, but to have the foresight to target interventions to an individual for that individual's own benefit is really kind of astounding. But it made it very hard to publish because there's no two groups and you're comparing an intervention versus a control group. That's not how this trial was designed. And so digging into the predictive biomarkers has given it a little bit more credence, for lack of a better term. But they received all kinds of treatments, We identified a lot of obstructive sleep apnea. So there was a lot of CPAP assessments and insomnia, receiving cognitive behavioral therapy, and anxiety and depression, meeting with a psychiatrist or a psychologist for talk therapy or medications if it was indicated, headache, migraine, specialty management. We didn't see that many cognitive specific issues. There weren't a ton of cognitive behavioral therapies in that aspect. And vestibular. Saw a lot of vestibular therapies that was needed for this population for sure. I can share those publications with you if you want to read them, or if you want to stick them in the show notes, whatever you feel is appropriate.
Yeah, absolutely.
that'd be great.
Put those in the show notes.
Mhm.
Some of your research includes a network analysis. Can you tell us a little bit about this approach and why you think this approach is uniquely beneficial for concussion research?
Yeah, the thing I like about the network approach that we've used a handful of times is it does a nice job of looking at the heterogeneity of symptoms, but also how they're interrelated. If you look at the post-concussion symptom scale, for example, or any general concussion assessment scale, there's symptoms all over the map for all kinds of things. There's no specificity to just concussion in there. But they are related to each other. And so that there's a reason they got in there in the first place. And so what network analysis can do, if it's used correctly within subjects, is identify what central pieces, what symptoms are specific to that person that are driving the rest of the symptoms, right? So there's network theory and all kinds of mathematical equations, but ultimately, roughly the center of a network is driving the rest of those symptoms. And you can see different strengths of relationships between, say insomnia issues and sadness, for example, and being highly interconnected. So we've used that tool a number of times to kind of get this out there, just promote this idea of heterogeneity, and that targeting to an individual symptoms is the best way to handle this injury.
Have there been any of the interconnections that you found using that approach that have been particularly surprising or really strongly correlated?
I'm not sure there are any that are particularly surprising to specialists within their domains, but to me, in general, as just a researcher, I didn't realize the strength of the relationship between vestibular symptoms and dysfunction and mental health issues. It can be extremely anxiety inducing to have an episode of vertigo, or to walk down a busy hallway and just feel confused, and the room is spinning, and you're that is what anxiety is in some aspects. So it makes sense once you think about it, but that was a relationship that I was very interested to learn about.
Yeah, I think it can be particularly challenging for athletes as well, who in some ways have their vestibular knowledge and their vestibular system working at peak at all times. So when there is some dysfunction in there, it can be challenging in multiple perspectives.
Yeah, that's absolutely right.
Have you guys been able to look at the directionality of that relationship at all?
No. So the best way to do that is with repeated measures within a person. So in theory, if you had a person who came into your clinic and you got immediate post-injury measures and then repeated measures over time, you could start to see directionality there from those repeated measures and collecting data prospectively. The analyses that we've done to date were cross-sectional. So we can't really we can't see causative relationships yet.
You recently published on the interaction between medical conditions and former athletes reporting symptoms consistent with premortem CTE. Can you tell us a little bit about your recent research and the findings?
Sure. Yeah, this is something that's super important to me as well. And it relates very much so to the mental health crisis after concussion. Um, but this was a collaboration between us and our department at the University of Pittsburgh and the Football Players Health Study at Harvard University. They've collected data in over 4,000 former NFL players and comprehensive health data across a variety of domains, including medical history related to diabetes, stroke, cancer, cholesterol, heart conditions, chronic pain, cancer, on and on and on. And obviously concussion history and issues with that as well. But one really interesting data point they collected was being told that you had CTE by a physician, yes or no. CTE is to date still a post-mortem diagnosis. It cannot be validly proffered in a clinic in a live individual. There's a lot of research dedicated to changing that. But definitely at the time this data collected and still to this day, it's a post-mortem disease in terms of its diagnosis. But Rachel Grashow and some other investigators there published a study in 2020 that found, I believe it's 3% of the 4,000 had been told they had CTE. When you're talking about 4,000 people, that's a meaningful number. Especially when it should be zero. What we did was we took those people and we wondered, so what conditions do they also have that made a physician think, oh, this person has CTE, right? So we used a decision tree analysis and looked at medical history reports and found that depression by far was the strongest association with being told that you had CTE as a former football player. Depression and anxiety was very strongly related to being told you had CTE compared to those with no psychological disorders at all. And also sleep apnea in the groups with both depression and anxiety magnified being told that you had CTE. And that makes perfect sense. Sleep apnea is depriving your brain of oxygen a certain percentage amount of time at night. That's going to have cognitive effects. And by the way, so does depression and anxiety, especially on the extreme ends. So the point of this study is just to reinforce the fact that this is a post-mortem diagnosis. Depression, anxiety, and sleep apnea produce these cognitive issues, but they are treatable. And it would be interesting to see if someone who had been receiving treatment or was successfully using CPAP and different depression and anxiety treatments, if those physicians still thought that they had CTE after receiving treatment.
Was substance use one of the variables that was looked at?
We did look at that, and that was not included in the final analyses. And that was something that maybe we thought could be, chronic pain was in there as well. And not just substance abuse, but performance enhancing drugs was included and did not come out for analyses.
And I guess sort of along the same lines as the question I asked earlier and what you just said, at this point, there's no research, right? On if we treat people for the treatable conditions, do they end up functioning better? But at this point, we don't know, at least not on a research level, right? I think probably anecdotally, clinically, we all have thoughts, but
Yeah, I've kind of adopted a saying that my Harvard colleagues have said over and over, and it's just treat what's treatable. There's no valid diagnosis for CTE and no treatments for CTE. There are tons of ways that you can get at depression, anxiety, and sleep apnea, and see if you're still concerned about that. My concern as a researcher, as a former football player who with head injuries, is you see constantly stories in the media of people going to very extreme measures because they feel a sense of doom related to being told you had CT, to having multiple concussions, because of the way that it's portrayed in the media, and that's tragic to me. And so what we're trying to do here is just say, hey, the story is not over. You can address these things and improve your quality of life, and that's really what we're trying to get across.
I think it highlights the necessity of the research that your group is doing and just more research with CTE in general. And then the next step would be to educate the public more broadly about exactly what you found.
Exactly. Yeah.
I'm curious how your understanding of concussions and their impact on mental health has evolved over the course of your career. What kind of things have you seen change? What more research have you kind of identified that might have impacted your conceptualization of how that looks?
Yeah, that's a really good question. One thing that really interests me is how these things present after the injury. I said in the beginning, we see some instances where it seems likely that a person had psychological issues before the concussion, but now they have a provider in front of them who's able to help them with that. So that chicken and an egg thing is difficult to parse out. We know that you injure the brain that you have. So what you bring to the injury is probably going to be magnified after the injury. And that's really kind of a fascinating thing to understand. And I'm still trying to convey that message with a lot of other people in this field who are digging into that. The evolution is really quite rapid in this field, and especially in this little sub area of concussion. I've had three that I think, at least I think I've had three. And my last one in college, I had a very anxious response to the injury, but I was told to go to my room for 2 days and close the blinds and isolate myself. And um, you know, big surprise when I got back out to trying to exercise and get my heart rate up, I was experiencing vestibular problems. I was experiencing what felt like panic symptoms. And I think that kind of drives what I want to look at and what I want to improve in this field.
I guess in some ways that kind of leads me to my next question of kind of looking at your research trajectory. What advancements do you hope to see in the field of concussion treatment, mental health support, and where is your research going?
I think it's going towards more valid objective assessments for these different things. We've failed at finding ways to treat this injury through randomized controlled trials over and over and over again. And I think the big reason for that is we're not targeting to the appropriate subgroups of concussion. We're still treating concussion as a whole in terms of allocating the appropriate people into the clinical trials themselves. And we've shown with our predictive blood biomarker work that if you isolate to the appropriate groups, you can find supportive, objective data to guide the way that you manage this injury. So I think contributing more objective data to all aspects, identification, assessment, management, long-term recovery, I think that will be my focus over the next several years.
I think that could really help move the field forward for a couple of reasons, but one that immediately comes to mind is if we have more evidence-based treatment, then we can help other behavioral health and mental health providers understand how to treat this injury. That, at least in the Midwest where I practice, that is a significant challenge, is finding people to do interventions with this group that understand the injury well enough to treat it effectively, to not, sort of exacerbate the patient's fears and, their attempts to withdraw and avoid things that cause symptoms, et cetera, et cetera. But if we can come out with something that's evidence-based and then at some level maybe a little bit more manualized, I certainly hear what you're saying about treatment has to be individual. But I think a lot of our mental health care providers who are doing this work day to day just are not well versed in this, and there's just not a lot out there, frankly, to help them understand this other than just sitting down and doing the training ourselves, and that's frankly just not a viable option. So
Yeah, absolutely. I hear you. I find a good way to talk to providers who are not in this field is just asking, do you know there are multiple types of concussion? And see their response. Because if it's one of shock, then they could benefit from a little bit of understanding that no one of these is the same.
I guess a follow-up question that I have to that is, I think lots of times the people who are doing the work know what questions to ask. I'm curious if you were interviewing yourself and we're like, this is the question that needs to be asked. Yeah, what's one of those questions that, because you're doing this every day?
Oh man, this is the question that needs to be asked about concussion as a whole.
About what you're studying in particular, as far as that intersection between concussion and mental health.
Wow, that is a big question. Pulling back to a 10,000-foot view, I think lending objective data to this, what I just said, is what we need. How much better would your life be treating concussion if there was a blood test that, even if it could just identify one subtype of concussion, or identify if vestibular therapy would work for this person or not. How much of a difference would that make in the way you manage this injury? I imagine it would be substantial. So I think those are, we've done a really good job at digging into risk factors and understanding response. And it's time to look into treatment and objective assessments of this injury in a more broad fashion.
And before we end today, just kind of staying on that same theme of kind of a broader view, is there anything else that you would like to touch on, or really take home messages that you want people to walk away from this conversation with?
Yeah. So one thing I like to, and this pertains to both concussion and CTE in general. This is another thing I've adopted from my Harvard colleagues, but it's never too early to get treated, and it's also never too late. I think I sometimes get the sense from people that they feel like they're damaged goods. They can't be helped at this point, that it happened too many years ago. And that's just not the case. There are many valid treatments out there for people's specific issues, as they're related to a concussion history. And I think at this point, in regards to, long-term issues after having a concussion, it's just really important, physical activity and sport participation in our youth populations are just massive contributors to how people end up becoming as adults. And I would hate to see those characteristics get lost because of fears related to head injuries. Yes, a lot of this stuff we talk about is scary, but it's manageable, and the benefits of participation far outweigh the risks, in my opinion.
Well, thank you for meeting with us today. I've enjoyed our conversation.
Yes, thank you both so much.